Today, we're going to spend some time hearing from amazing supervisors across the educational spectrum. So we'll have folks who are supervising master's trainees, pre-doctoral trainees, and postdoctoral supervisees. We hope this will be a really good discussion. And as you can notice, the Q&A feature is on, but the chat is not. So we would definitely love to hear from you and have you add your questions to the chat in that process. Do want to note that this webinar will be recorded for future viewing. So if you had folks who were planning to attend or you want to share this with other people, whether to get some ideas or to receive some validation, it will be posted on the SPC's YouTube channel, which the link will be added to the chat soon. And as is the way when you join a section's webinar, I do want to put in a plug for our section. So the section on supervision and training is dedicated to those interested in engaging in supervision and training for mental health service providers. And we don't restrict it just to professionals. We definitely want to create space for students who are interested in this sort of work early on, so we can help cultivate our future generations. We work to collaboratively promote multiculturally sensitive research, teaching practice, and public interest for therapists in training, clinical supervision, and feel this really aligns with our past, present, and upcoming presidents for Division 17. So again, being mindful of our time, I'm pleased to welcome our panelists. We have Dr. Aisha Woods, Dr. Marvis Marcus, and Dr. Heidi Christensen, and I will let them introduce themselves in that order and let them explain a little bit about who they are and what they do and how amazing they are. So Dr. Woods, it's all yours.
I thought Marvis was going to go since he was off mute, but okay. Good afternoon to everyone. My name is Dr. Aisha Woods. I bring you greetings from San Antonio, Texas, the original land of the Paella Indian tribe and culture. I am a psychologist in training, should I say, or after training, right, postdoc. At San Antonio College, which is the #1 community college in the United States, just won the Aspen Award. I work at the Student Advocacy Center, where I carry, of course, a caseload working with our students here. We have a community of about 20,000 enrolled. And there are 2 clinicians here. So with that, I also am responsible for the practicum program. I am practicum program coordinator, supervising master's and doctoral level mental health graduate students. So thank you so much for having me.
Thank you, Dr. Woods. Dr. Marcus.
Very cool. Thank you. Well, good afternoon or good morning to everyone. I trust all of you are well. I'm Dr. Marvis Marcus, and I use he, him, his gender pronouns. I am coming to you from Durham, North Carolina. I am a staff psychologist and the director of training programs at Duke University, Counseling and Psychological Services, where I had the great fortune of working alongside Dr. Woods. So much respect to her. And I do all things training at Duke University. I provide clinical supervision and education. I also engage with our trainees, our master's level trainees who also are part of a cohort of 5. And I do a lot of clinical work, which I enjoy immensely, specifically around, I'm doing more and more eating disorders work these days. And so I feel really fulfilled and edified by that. So thank you so much for having me.
Thank you so much, Dr. Marcus. And last but definitely not least, Dr. Christensen.
Hi, my name is Dr. Heidi Christensen, and I'm a psychologist at the Medical College of Wisconsin in Milwaukee, Wisconsin. We are in a medical school and an associated academic medical center. And we have, in my role, I'm an associate professor, and I'm also the director of our health psychology training program. So we have a pre-doctoral internship program, which is our health psychology residency. And then we also have a postdoctoral fellowship in clinical health psychology. So in my role, I do a lot of management of our program, supervision, and then also I'm a health psychologist, counseling health psychologist at that works with folks with cancer. So I look forward to being part of this panel.
Wonderful. Thank you so much, everyone. So like I mentioned, right, we want this to be conversational. So I'm just going to kind of put this out there, knowing that we've been in this pandemic situation and we understand how it's directly impacted training, certainly at the onset, but we're still seeing some of those ripple effects. What are some of the things you've noticed about these current cohorts that maybe feel different from past cohorts? And I'll just let whoever feels like the spirit moves them to go first.
I'll briefly answer that. As Dr. Marvis had mentioned, I spent my predoctoral internship at the wonderful CAPS at Duke University, and I am a part of what we have identified as the COVID cohort. We started fall 2019, March 2020. Of course, when the pandemic hit, we were at the tail end of our experience. And here I am now where I am providing supervision to 3 master's level clinicians and 1 doctoral level clinician. And what I am experiencing in this supervision is a lack of preparation. It is evident that that year where most of training and academics would have taken place face-to-face, and there would have been some on-site practicum experiences and maybe even, live supervisions and things of that nature did not happen. But in an effort for programs to status quo, keep moving, keep going, keep graduating, I have been experiencing some difficulty in acknowledging that a few of my practicum students are not where they probably should be based on how long they have been in their programs. And we're not very far removed as students, right? I'm 1 year out from graduation, but there seems to be a very big gap in between where they are at this time in their academic process and where I was at that time in my academic process. And it's just rather evident.
Very cool. I will mention there are a number of things that really stand out to me. But one in particular would be training and education around crisis work. Walk-in triage processes have been somewhat difficult, maybe more so for our master's level folks. And I think when you have a cohort of people with different trainings, what you bring to the table can be really, or the way in which you want to train, I should say, can be really difficult because people are on different pages. And I think that that's become more apparent during the COVID times. And so in my particular agency, we've really had to slow down our processes around walk-in and crisis appointments and spend more time with our trainees, which is certainly something welcomed, and we feel really that it's an important learning curve for our trainees, and it also requires a lot of labor. It impacts the system when 2 or 3 people have to join in to help with triage covering the triage system or shadowing interns. And so that's something that stands out to me when I think of that question.
Well, I think where, to respond to this question, I think where our program is probably is a little bit different, although I think we might see different phases of this for several years out. So I'm always kind of hesitant to say how, what I might say right now, it might be different in a year or 2. But what we've noticed is we've had, except for our first year where we pulled everyone out of the hospital, really once personal protective equipment got back into a way that was stocked appropriately, and we felt like we had a really good control over how to have patients being seen in the hospital in a safe way. Now our trainees are in the hospital, so we still see I haven't seen as much of a deficit in skills but yet I'm seeing people at the internship and the postdoc level. And so that time, I mean, if you're a master's student and you've missed your first prac or you've missed your first pre-prac, that's really hard versus, we've got some people who've just had some years under their belt. But what I am noticing that's a little bit challenging is working in healthcare right now is hard. So we're seeing a higher level of anxiety in trainees, and different anxieties about working around patients and potentially leaving yourself open to infection, even though our current round of psychology residents do not see necessarily COVID positive patients, but a higher level of anxiety in general. And then also something that's a little bit more challenging is it's been harder to have our cohesive group, which I think is leading to a higher level of anxiety about being in a new place. And so feeling like, you develop those relationships in place and space, although it definitely happens during the supervisory process, there was a lot of community building that occurred when people were in the same space. So we actually do have, so last year we had one clinic entirely virtual. And this year, although it's virtual for the patient care, we have our residents coming in, and we're really working on kind of rebuilding our community, which has been a real challenge because when you move somewhere for a year, you don't know anyone, and you really can't go out and about and be part of the city. That's where I've noticed, I think it's been hard on the socio-emotional side of trainees.
I'm really glad you made that point of the connection and the impact of telehealth. And I'm sort of wondering, where at all of your sites and the work that you're doing, what is your proportion of telehealth that you're having your trainees participate in?
So of my 4 practicum students, 3 have never seen a client in person, which is intense. And they are on site 1 day a week, but still delivering services, of course, telehealth. Notice just came down that if a client requests in person, we are to provide that. And come January, that will then be the norm. If the client, for whatever reason, requests telehealth, we can provide it, but the norm will be back to in person, and they are nervous.
Yeah, I was just gonna say, can you imagine the level of anxiety if you've not seen a real life client in person? Holy cow.
Yeah, they are nervous.
Wow. So variable. So at Duke, we have been back in the office full time since August. And all 5 of our trainees are required to be on site and see students in person. And so that's come with a number of different reactions, as you can imagine, and understandable anxieties, right? And currently, each of our interns have service delivery for 1 telehealth client on their caseload, but everyone else is to be seen in person.
And I feel like I may be the little bear in the middle. So we have at our site, so we're an academic medical center, and the first 3 days of the week are in our site, they're called residents, but our interns are seeing patients in the hospital live. So they're on rotation, seeing people, and then doing some like pre-transplant evaluations. So those are live, and they're part of a multidisciplinary team. And then on Thursday and Friday, they have a continuity clinic. That continuity clinic, they are now physically on site, which is on our outpatient department of psychiatry, but they're still delivering that via telehealth. So that was one thing I was going to mention a little bit to your earlier question, is that I do think there is a real advantage to learning how to do telehealth. And we've noticed actually some of our trainees coming in with more experience doing telehealth, and then also just a broader range of skills doing telehealth. We were pretty lucky that we just happened to have a faculty member who actually had expertise in telehealth before this occurred. He had set up telehealth clinics for rural healthcare clinics before all of this. So we really saw that as a training positive side. But yeah, so we really have a balance of both in person in the hospital, in person outpatient, and then virtual via telehealth.
Yeah. And I do want to remind folks that since we're sort of at the quarter of the way through our time, if you've got questions or you've got thoughts, or just please don't hesitate to put them in the Q&A section. We would love to hear your voices and whatever that looks like. So yeah. So I'm wondering also if we can stick with the telehealth idea just a little bit, right? And balancing the benefit of it, because we have the potential of reaching more historically underserved populations if they have the ability to access the necessary equipment and technology to do that. But how do you imagine sort of long-term impacts? Will you keep telehealth as part of your training experience moving forward? Or will it be, as soon as we can go fully back to normal, like telehealth, be done?
I think for our institution, it might be around in some capacity for the years to come. Ironically, I would say for the bulk of the pandemic, we collected data from students in terms of their preference for telehealth, and we got an overwhelming response rate that suggested that students did in fact prefer telehealth, mainly for its convenience. But the numbers have really shifted since we've returned back to campus. In fact, more and more students are asking or requesting in-person appointments. In fact, when they come in, they have the option to see a counselor in person by way of telehealth. And then of course we solicit their preference if they move forward for ongoing care in our office. And the overwhelming majority really prefer in person. And so we're still trying to make sense of that. I think we can make some pretty clear inferences, but it was something that we were just not expecting. And so in August, kind of like at the last minute, we really had to shift a lot of our processes because we thought we were going to be a more telehealth, offering a more telehealth model, but that just was not going to be viable. And so I think it will be around in some capacity moving forward. I can't imagine it not being, but probably won't be the bulk of what we offer.
Yeah, I think that aspect of like client preference, right? That's going to be a huge driver for those sort of things if they have the choice.
Well, and to that point too, we've been actually running across a really interesting dynamic of, and the way we've been approaching telehealth, excuse me, so anyway, is client preference yes, but then also looking for like indication for the client. So sometimes we'll have, I mean, we definitely have patients who might prefer telehealth, but we really notice a huge disparity between socioeconomic and racial disparities on access to internet, access to a safe space to actually talk. A lot of people taking their telehealth sessions in their car, taking their telehealth sessions with their kids there. And so it's really a different experience depending on how many resources you have in the home too. So we're really trying to encourage coming up with the clinical rationale for why we're doing telehealth. We're trying to, for our trainees and for our patients, we're trying to minimize doing it as a source of avoidance, and we're trying to maximize doing it for a clinically relevant reason, which there's plenty of those for us because we work with a lot of immunocompromised people or patients that are coming from very far away. I've also noticed some differences in different age groups. So I'm not sure if both Dr. Woods and Marcus run across that, where there's a different feeling about that depending on it. So that's really where our next goal is as we're working on our recruitment season for our next round of psychology interns and fellows. Is like, how do we not make this about, this is something that I just feel more comfortable with, and how is it the indication?
Mm-hmm. Yeah, that's a really good point.
It's an excellent point, especially when I think about the demographic of the students that we service here. My youngest client is 17, my oldest is 62. And they are community college students. And you do see a very huge swing in preference for in-person, and individuals that are single parents raising 3 kids, and the idea of driving to campus for a session is just not feasible. But literally being able to say, I can take a session in my car by myself in a safe environment during my lunch break, and my therapeutic work is that important to me. So we make sure that we have the conversation and training about how telemental health is going to provide access to a number of students that physically are not here on campus, that their entire programs are what we call like the allied programs, the CNA nursing and things of that nature, where now they have access to these services, where actually prior to COVID, it would be a requirement for them to come on campus, and it just wasn't feasible. So that's something that we have continued to talk about, even in the way that we offer workshops and we offer groups. If we offer them in person, we try to figure out a way to do the same thing virtually for those individuals that don't have the capacity to make it onto campus.
Yeah. So we do actually have a question from a participant. And I think as I was reading through it and listening to you folks talk, I sort of found myself chuckling, because it's like, even before telehealth, right? We were maybe struggling with this a little bit, but the question is, or statement rather, and then a question. I mostly work with beginning prac students and have noticed a big difference in the ways our students prepare for their therapy sessions with clients and are tending to try and script most of their interactions. And I just think of that first prac student, right? With their little notepad, and they're like, I'm going to ask all these questions in 10 seconds and you're going to answer me, right? So how have we noticed this, and how are we working with students to help them rely less on scripts and be present during their client sessions?
I think I can speak to that simply because I have master students, and this is their very first time.
Yeah.
This is their very first time doing clinical work in this capacity. And the analogy that I use is, this is building a house, right? That script, the training, your academics, that was laying the foundation, that was laying the plumbing, that was laying the pipes. Here in your practicum program, we're standing up walls, we're standing up the drywall, we're going to build on that. One of the things that you will stop doing is relying on the foundation, because you're going to trust that concrete's there. You're going to know that you can rely on that concrete foundation. You won't have to have it in your pocket. So get comfortable with the idea of what it is that you know. So we spend a lot of time talking about developing a therapeutic voice. What does that mean for you? You're a holistic person outside of just what you've been trained. How do you bring yourself into the room? Your cultural aspects, your background, your beliefs. And those are the conversations that I notice start to make them become more confident in who they are as a clinician. So it starts with the paper, and then all of a sudden the paper's to the side, and all of a sudden the paper's not in the room. So that is something that we continuously talk about, to not be so reliant on a foundation that's stable, that you know that you can trust as you continue to build on your therapeutic voice. So that conversation happens pretty frequently. And now it's kind of starting back over, because it's like, oh crap, I have to see these people in real life. Like, I need my notepad, and I need my notes in front of me, and
I need my safety blanket.
I need all of it. And I'm like, that's fine. Take it, have it with you. If something happens and you need to rely back on it, by all means have it. But understand that at a point you will get to a place where you will not have to rely on that foundation, because you will know that it's there and it's set in stone.
I love that metaphor. Thanks, Dr. Woods.
Yeah, it's a wonderful metaphor. I'm still kind of formulating my response to the question, but I will out myself as someone who needed a secure object. And so I totally get it, and have a lot of compassion for students this day and age.
Yeah, I like it. Well, I'm also thinking, as we hope that students progress in their clinical competency, right? Attunement is a big part of that. And even as we were preparing for our time together, noting that minimizing distractions will be valuable, but how easy it is to have your email tab open while you're doing a Zoom session, right? And how quickly just those little things can pull our attention away, and how that takes away from the therapeutic relationship.
Well, that's funny, Cody. That's exactly what I was thinking, is that as a clinician, the mentality is totally different, because when I'm working on my computer, I might have a document open and I'll toggle to my email and I'll look at my text messages. It's just the way that we orient around this computer. And so in many respects, it is required for me orienting myself around seeing a client flat. And that's very different. And so I think having conversations around, and being open and honest about, this is just a very different thing. And we all use technology in so many different areas. And very rarely do I sit on technology, if I'm just using it in any other way. Like if I was just working and not having a seminar, would I sit there for a full hour at a time? And so it has a very different feel to it. So I think discussing that and acknowledging it, and then kind of figuring out strategies to orient to a person in a very flat way.
Sure. Something that I will add, and it may sound relatively small, but it's a conversation that I'm often having with trainees, is talking about Zoom etiquette. And so I really try to model what I think is good Zoom etiquette in staff meetings and more informal meetings, because I've noticed some wonky things over the last year or so. And I would prefer not to be that person that has to have that conversation about like, well, what were you thinking here? Or you do realize that I can see the white screen in your glasses, or like those types of things. And so I really try to, to the extent that it's possible, model really good present behavior, irrespective of the meeting that I'm in. And hopefully that is, trainees are internalizing that as something that they ought to be doing as well.
Yeah. We have another question. So an invitation to talk about supervision models being used now that there's the combination of telehealth versus in-person clinical work. So example, tech wisdom on reviewing session recordings, observations regarding feedback on skills and implementations. And I just think there's a lot of richness to this question. So I'm wondering what your all thoughts are. And I can repeat it if you need me to.
I can try to answer some of this, but it's a lot of questions, so maybe I'll get a chunk of it. So what we've noticed, we use a competency-based supervision model, and so we're very focused on competencies on really everything that we do. And so what we have noticed is really our model is we like to first observe, have a trainee observe us, then we observe the trainee, and then they kind of fly on their own, and we review their notes and kind of check in, right? So we really try to mimic that same model in a telehealth environment. We just do it a little bit differently, which has had some ups and downs. So we would have people before in our outpatient clinic, we would have cameras in the rooms. So the patients would sign a consent that they were being recorded, but there was no real intrusiveness to it. But then we were not recording our telehealth sessions for a period of time because we did not have the technology to do so. So then we had to have our supervisors kind of just jump in and deal with the dynamic as, how it impacted the supervision or the client session, right? And that actually changed over time as we had the ability to record. So really it's been a matter of taking the core elements of what we're doing. So ours is competency-based supervision and how we review and how we provide feedback, and the fact that we had facilities to look at recordings, and then being able to try to model that in a telehealth world. And I think it was a little easier on our side too, because that Monday through Wednesday, we were still doing live supervision. So we were still, because it makes sense in an academic medical center, you walk into the whole flock of people, it doesn't make much sense in an outpatient session. So I think I got a section of that at least.
For sure.
I think the same thing happens here for myself and my practicum students. I offer live supervision via Zoom. We let the student ahead of time know that I will be sitting in, my screen will be black, and I will be on mute, so I will not be participating in any way, but I am going to provide that live supervision. And this was what let me know, uh-oh, Houston, we have a problem. As I'm watching one of my trainees deliver services, and I'm recognizing, uh-oh. And after that, had to have a talk with my director and say, we are going to have to, one, reduce my caseload in an effort for me to be more available for live supervisions. Two, I need to be very spontaneous in live supervisions and give you about a 5-minute notice that I'm coming. And three, we need to be able to record. So we were able to make some modifications to our informed consent. And what made that kind of difficult is because San Antonio College is one of 5 Alamo colleges that operate as a district. So if our informed consent changes, it has to change for the other 4 institutions. So it's a whole lot of red tape, a whole lot of, and 2 out of the 5 schools don't even have practicum students. So it was like, well, why are we doing this? Why do we need that? So that became somewhat of a source of frustration, as I felt like it was slowing down the training process for myself. So I broke a couple of rules and I said, well, this is what we're going to do. But it proved to be very, very helpful, even for the practicum students who were now getting real-time feedback of where their strengths were in a room and areas and opportunities for growth. So that has now become kind of a weekly model on top of individual supervision.
So I just want to make space, Dr. Marcus, if you had something you want to add, but no pressure.
No, I'm fine. Thank you.
So we have another question, and I think it's a really good one because I know that pretty consistently for the past few years, we've been grappling with this idea and concept of professionalism, right? So how do we decolonize, dismantle white supremacy and this definition of professionalism? So we have a question related to professionalism while providing telehealth. What can be a decolonistic perspective for this? Also, AKA letting go of things that are relics from white male supremacy versus what works more flexibly with diverse clients and supervisees.
This is a really good question. I often enjoy conversations about professionalism, although they can be really hard. And I notice that even as I engage in those conversations, I often have to self-interrogate around things, around the ways in which I've been socialized that may be emblematic of white supremacy, and also managing my own expectations, because there are things that I think are quote unquote right, or the standard way of showing up as a mental health professional that may be very different from how another person conceptualizes being a mental health professional. But I would say that I've had the most success in engaging this very fraught topic with just asking interns about how, in what ways do they track how their behavior impacts the therapeutic alliance, right? And so really trying to invite them to think expansively about how they engage with clients and how they manage. Because I think that my experience has been thus far is that when the word professionalism comes up, it can kind of have like this, just like flight or fight response, I think, for most of us. And I'm all about, the being critical about these ideas around professionalism. And we have a stimulus value as individuals. And our stimulus values can be very different depending on our intersectional identities. And so I try to put the onus on the trainee to think about their stimulus value in the context of the therapeutic alliance and how they are tracking feedback from clients around their stimulus value. So that's what I'll say to begin.
What other thoughts are we having about?
I'm having a lot of thoughts. I'm having a hard time kind of thinking about a really great way to, it's more thought-provoking than anything I have a great answer to. I do think one thing I've noticed about telehealth for myself as a clinician and helping, and then I guess observing my trainees and then helping my trainees is that the level of intimacy physically about the inequities in our, like the level of intimacy that telehealth requires really highlights some of the inequities that are kind of out there in the world, and also really does allow us to question things and think about things a little bit differently. So one patient that I see is a young patient. I think she's more comfortable in a telehealth environment, and she lives at home alone, and the way that she engages with a session is really about like kind of taking her phone and like walking around her house, right? And from my perspective, sometimes it feels kind of like weird or disrespectful, but then when you pause, you say like, well, what is that about? Like, why does that have to be that one particular way? Like moving and walking around really seems to fit particularly those persons. And I think there's an intersectionality between her her age and her race. So really it's kind of like the combination of the two makes it feel a little less stuffy and let's just stare at each other in a weird way. So I noticed that you can be very professional and mindful that you're actually doing therapy and you're doing work, but give people a little bit of latitude on how they're actually doing that. But I still think that's like a tip of an iceberg that we have really, before we used to talk about like, what does your office look like? What do you broadcast in your office? Like I have pictures of my kids over there. Now it's like, you're my house. This isn't my house, but like for a period, this is my office, but for a period of time, you'd be seeing my house, then you'd see your trainees' houses. So I think that broadcasting, you know, really amplified. So again, I don't know that I have one great solution, but I think it really is elevating the question in a really positive way for our entire field.
Mhm.
I would absolutely agree with that. The conversation about professionalism here, I think in my experience, is some decades behind. There is a lot of white supremacy, patriarchy rules, still to the conversation, almost down to dress code. And I'm like, it's 2021. Are we really talking about the shoes someone has on? Like, let's, there's so much more to discuss. But kind of like Dr. Marvi said, he finds himself having these challenges of kind of how he's been. And then I caught myself doing the same thing, wanting to have a conversation with a trainee about how they were presenting from this part up, because that's where they were in session. And there was some that looked, slightly disheveled and things of that nature. And I'm like, I don't know this person's full story. This might not be disheveled. This might be by choice. And I started circling, like, how do I have this conversation? Do I need to have this conversation? Is this person's appearance impacting the way they deliver services? So it's been really interesting, honestly, because I have not figured out how to tackle the conversation in a way that's going to be both productive and helpful, and not to continue to perpetuate things that we already know are harmful and hurtful when it comes to professionalism and how students are appearing or how trainees are appearing. So yeah, it's a very good thought-provoking question.
It is. It is. One last thing that I'll mention is, while I really invite conversations around, like, problematizing some of these perennial ideas around professionalism or conduct, those types of things, I really invite interns, again, to think expansively. So I'm of the opinion that we can't stop with the critique. Oh, that's white supremacist, and so that's just the end of it, period. We have to move beyond the critique. The critique is perhaps the starting point, and I love the critique, but that can't be the segue to do whatever we want, right? And so, like, our decisions, there has to be, in my opinion, a decision-making process or some kind of introspection around the stimulus value, the culture piece, the engagement, because we are human beings, right? Full of contradictions. And so I think sometimes in my conversations with trainees, or even colleagues for that matter, the conversations stop at the critique. And it's like, oh, well, we shouldn't do that anymore because it's white supremacist. And it's like, well, we have to move beyond that. The critique can't be the start and end point. Otherwise, to me, that seems intellectually lazy, if I'm being frank. So,
yeah. Well, and I think it doesn't create space to acknowledge the trap that we are in, right? Like, I'd like to believe anywhere where a counseling psychologist can be found, like, we can create a safe pocket. To explore these ideas. But when you get out into the quote unquote real world, how do you navigate those systems continually? Because we need to get diverse individuals to degree completion so that they can start affecting change by getting into those systems, right? And whatever that system looks like, if it's politics, if it's just getting a job at a place that maybe you're the only historically excluded population identity person, right? But also staying connected to your professional networks to keep safety and your own self-care happening, as long as it's safe, right? I had a colleague who I was connecting with over lunch, and she happened to be in West Virginia, and is a Black woman, and was putting groceries in her car, and somebody decided to stop their car and yell racial epithets at her. And she's just like, why is this happening? So, right. So it's just like, I'm done with this, get to a safe place. And I think that if we can create those safe places and make those small changes, it can be really helpful. So yeah, I know, right? So we have about 18 minutes, so everybody can roll off to their next meeting. I'm not seeing any questions that have been posted. So definitely want to invite more folks if you've got thoughts or reflections that you want to offer. Thank you. Curiosity about our thoughts in terms of addressing generational differences with trainee cohorts.
Do you mean like our generational difference with the cohort, or the generational difference within the cohort?
That is a good question. How about both?
Wow, think about that. Oh, and I think the other thing that's important to keep in mind is there's these stamps too. I feel like the pandemic is this as a stamp. You know, it's kind of like the Great Depression itself becomes kind of a generational stamp.
Mm-hmm.
So I think there's almost like three things. There's definitely a generational difference between myself and the trainees that we have, and then there's variability within our cohort. But then there's also a stamp of just having. Some people have trained mostly through this pandemic. And so their experience of understanding what it is to be a mental health provider and their socialization into the field is very different. So.
Nice.
And I think to kind of piggyback on that, these individuals that I'm having the privilege of supervising at this leg of their journey, being that they have been trained almost primarily in the midst of this pandemic, has them questioning whether or not this is going to be a long-term fit.
Mm-hmm.
So there's a lot of discussion about what quote unquote therapy life was like prior to the pandemic, when they might have been working on undergraduate degrees at that time and still trying to figure out what it was going to look like, to now being in this very hypersensitive, hyper-racial, hyper blah, 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 right? Will it ever calm down and we just work with people who have test anxiety? Will it ever just go back to interpersonal relationships? Like, will that be the case? And the truth is, maybe not. And we need to have a very realistic conversation about what the fallout is going to look like once things return to what we would identify as a status quo, and how people will, from years from now, be grappling with the experience of COVID-19, and how you as a trainee have been trained in this very, very intense crisis almost every other week, you know, this type of circumstances where generationally that actually was not my experience.
Mm-hmm.
And what does that look like? How does that shape you professionally? Do you want to be in private practice? As a result of this, have you decided that you're not going to go into, you know, a hospital because it's going to be too high of an anxiety type place for you? So that is a good question, because generationally, this COVID experience has really changed what mental health is going to look like currently, and the individuals being trained in it, hence us here having this conversation, and how that's going to affect them as clinicians moving forward.
Mm-hmm. Well, and also owning the fact that very rarely do we have the opportunity to be going through the same things that our trainees and our clients are going through, right? So that point being it. And that actually, there's been two questions that have come in, and there's one that I think dovetails really nicely from what you two were just describing. So we previously mentioned about the delay in trainee readiness and possibly as a result of the pandemic. How, if at all, are we evaluating and gatekeeping, or how have our evaluation and gatekeeping approaches been modified?
I think we were lucky enough. I think this is a really hard approach, and I think it's harder depending on like the length of your program. So I don't think anyone wants to like penalize a student for not meeting competency benchmarks when they've done it in this context. I feel like I've run across it less, just for the fact that we have people who've had more opportunities and they've been in health settings. But I think it's a really hard question. So if you are, you know, we hate to penalize trainees for not having the opportunity, not having the most hands-on training that I had, for example. But I do think we have to, the way that I think about all competency issues is I think about them not as in like you're good or bad, you're doing this or you're not, but as we're working together toward a common goal. And we really need to work on identifying what is the competency and what are the behaviors we need to do to get up to that. That being said, I really am catching people late in their training. And I think this has got to be really hard on people earlier in their training. And that's a great question we all have to grapple with.
Yeah, it is. And admittedly, I don't have a, I think I could talk about this for more time than we have, because it's just such a complex and intricate issue. I'll first mention that this kind of question or topic, it makes me sometimes feel like a bureaucrat. And I don't like feeling like a bureaucrat. Because I have to think of like programmatic things and manage that alongside the US Department of Education or accreditation standards and expectations. And sometimes those things are in conflict with each other, and then the agency has its own needs and expectations. And so as a training director, I can be pulled in a number of different ways, which is exhausting. And so with the training team in particular, I try to have ongoing conversations with people about the ways that we are going to loosen or reconceptualize some of our benchmarks in the areas that we can. Is because there are a lot of areas where that is just not possible, or I have not won those battles, right? Like I'm still in conversation with so-and-so who has put me in contact with so-and-so to even begin a conversation. And so that is quite challenging. But I try to get us, at least the training team, on the same page where we are clear on a task or a common goal, and feel prepared to have conversations with trainees around what we need to see, and what the common goal is. And I've been semi-successful there, but it is very, very difficult. One of the things that comes to mind for me in particular is videotaping counseling sessions. I work at an institution where legal counsel is extremely conservative and stringent with respect to audio and videotaping sessions. Dr. Aisha will recall that quite clearly, I'm sure, and probably is still recovering from the mind nature of it. But that's just one of the material examples. And audio and videotaping sessions is such a powerful feedback tool that is different from live observation, which comes with its own pros and cons, but also detracts from the system, and because 2 staff members have to be present for that. And if 2 staff members are present for that, that means 1 student is likely not being seen, right? And so then it becomes this productivity issue. And no one, I don't think, likes conversations about productivity.
No, very true.
The word gatekeeping literally does something to me right now in this season. I'm not comfortable with the amount of power I have as a supervisor to determine literally someone's academic journey. And I'm sitting with that as I am recognizing there is someone I'm working with that I know is simply not ready. And doing everything in my power to get this person to where they need to be, but it's a very strong indication that this just isn't their time right now. And the difficulty with that is that if I make that call, I know this person will not graduate on time. That's a problem for me. That's a problem in a way that I have had to rely and pull in leadership to help guide this conversation and this decision and things of that nature. And that becomes difficult when they're not psychologists. That becomes very difficult when I'm working with individuals that really don't have a concept of what it means to be a mental health trainee. Because they will provide information and support in a way that doesn't help any of us. So then I'm kind of left to, well, let me reach out to my outside folks and have this conversation and this dialogue about what to do to either try to fill that gap that's missing, and then recognizing time, resources, it's not on our side to do.
Right.
And what do we do now to try to remedy this situation? Because as you stated, this pandemic is not any of our fault, but now individuals are suffering and are not where they need and want to be as a result of this experience. So it's really tough.
Very accurate. And I did get a message from our amazing moderator, Asmita. So I do want to name the recognition of supervisor support being really essential as we address the lack of readiness in some cases. So I hope that you feel like you have connections with people who are on your same wavelength to support, and also definitely consider joining our section. Just want to put that as a plug in there. This is my own internalized white supremacy surfacing its ugly head, but I do want to be mindful of our time. Dr. Christensen, I recognize you unmuted. I just wanted to make space for you too.
The only plug that I was going to make with regard to dealing with any issue of competence, if you're training at the internship or postdoc level, is APIC. I have found APIC actually has a, we're not going to get the name of it correct, but it's the informal resolution policy.
Informal problem consultation.
Thank you. I know if anyone.
Why do you think I know that, Dr. Christensen?
Like, oh my gosh, Heidi, you got that name wrong. I think that's the important part with any of it, is because I think about remediation not so much as, because we can definitely feel like, oh my gosh, I am holding this person down, and I am. But another way for me to think about it is, this person is not ready, and how do we help them get the skills that they need to get ready? And a year, taking a year break and getting something, it's really important, because when you're out there in the world, you'll have very few people to support you. So that's another resource that it's a really great for the internship and above training community.
Yeah. And can I quickly mention something, Dr. Walls?
Yes, please.
Yeah, I just wanted to also give you a shout out, Dr. Walls, because you helped me through a very difficult time with respect to a training matter. And so I think it maybe goes without saying, like, use your network or create a network. I sometimes feel like I'm in a sea adrift. And I can't even remember how I got connected with Dr. Walls, who I think we had about a 45-minute conversation. Either I was on walk-in hours or she was, but we were like multitasking, and the conversation was just so helpful to me. And so I've been able to identify just a small handful of people, and those are my people. Where I feel lost, and I'm like texting or emailing those people, and they get back to me immediately. And sometimes I think that the conversation is going to be long and drawn out, and it's not. We can literally exchange a couple sentences, and it's like, okay, that was really helpful for me. So I just wanted to, give you some love.
Thank you. I feel that it means a lot that you wanted to share that. That means a lot. Thank you. So there were a couple questions that we weren't able to respond to directly, but I added them to the answered section, even though we didn't get a chance to answer them. So I hope you'll take a look at them. If you recognize the names and want to contribute or respond and have their contact information, please feel free to do so. But again, to be mindful of our time, I want to extend a huge amount of appreciation to our amazing panelists for taking the time out of their day to talk with us about this. Thank you so much, everyone, for coming. And for those of you who asked questions, I hope we were able to get those answered. Again, this will be posted on the SCP website, YouTube channel, which a link is there. And then also, if you're interested in joining the section, the link to apply for that is in the chat as well. So I hope that you all have a wonderful upcoming rest soon, and that you're taking care of yourself, listening to your bodies, listening to your soul, connecting with your people, and doing what you need to take care of yourselves. So we hope you all have a really good one. Thank you.